and thanks for the invitation to speak, Pavel. And Alex and I are here today talking about how we developed a platform protocol for a trial to test complex interventions. So this is the area that we work in, and it's not usual to have platform trials in complex interventions. You've heard a lot about drugs and vaccines and so on. So we'll talk through some of the challenges. I just want to sort of start with this sort of probably depicts what our perception of developing a platform trial is like. They're very complex, there's lots of moving parts, and they need to fit together seamlessly to achieve the intended efficiencies. And what we're going to show in this talk is how it takes essentially a village full of people, each bringing their own skills and experiences and working together to put the cogs together to design an adaptive platform trial. And we'll illustrate this through our case study of our Life After Stroke platform. And here is the village of people that I'd like to acknowledge that have all been involved in developing this platform protocol. Alex and I here on behalf of the team at the University of Leeds, and our academic collaborators include Pavel from Cambridge. And I'd also like to acknowledge that the work that we're presenting today was funded by the National Institute for Health and Care Research via a 12-month Platform Acceleration Award. So just a quick outline when we're going to talk. I'll talk briefly through what's a stroke and why we might need an adaptive platform trial for life after stroke. And I'll tell you a little bit about how we went establishing the platform collaborative. And then Alex will talk through the proposed platform design and how she worked through some of these knotty problems with Pavel, and then we'll end with some reflections. So just to set the scene, as you may know, a stroke occurs when the blood supply to part of the brain is cut off, which can cause brain cells to be damaged or die. And strokes can happen to anyone of any age. And in fact, every year, over 100,000 people in the UK will have a stroke. It's the fourth largest single cause of death, around 38,000 deaths per year, and is the leading cause of complex adult disability. Due to research that's led to better emergency and in-hospital care, many more people now survive strokes, but are then left with multiple long-term conditions. So there's a phrase in the stroke community about more survival but do not thrive. These long-term effects are shown here on the screen. For instance, around 1/3 of stroke survivors have a moderate or severe disability, 1/3 have a mild disability, and more than half experience anxiety or depression. And despite several previous pragmatic trials, we really lack effective interventions to address these long-term conditions. And those previous trials have tested single interventions in 2-arm trials with fixed designs, and the evidence generation has been slow and inefficient. So clearly this is an area where there's a need for more efficient research to better understand multiple treatments and to answer multiple questions in the same study. However, there's been very few adaptive platform trials in this area, and most, as I've said, have been designed to test interventions such as drugs and vaccine, which then leads us on to our platform award. You can see the aim here on the screen. As I've said, there's not only are there very few trials of platform trials of complex interventions, but there's very, very little guidance that's specific to these platform trials that might evaluate interventions such as rehabilitation interventions that would help with the long-term effects of stroke. So the Platform Acceleration Award gave us dedicated funding and time to develop a new protocol for an innovative and inclusive national platform trial. And it also allowed us the opportunity to gain practical experience of developing a platform trial to test these non-pharmacological interventions or complex interventions. So you can see here on the screen what we were setting out to do. These are our 7 objectives, and the ones that are in green are really what we're going to focus on today. That final objective, we're really here to help disseminate some of our learning to the research community. And if you want to know more, there's a full report in an open access report in NIHR Open Research. And you can see there on the screen some of the activities that we undertook to develop our platform protocol. And what we're going to really focus on today is some of the aspects of the optimal platform design. So I'm going to talk a little bit about how we established the platform and how we established the platform collaborative. So when we started this work in 2022, there was a distinct lack of awareness and virtually no experience of platform trial designs across both the clinical and research communities in stroke. So it's essential to undertake a comprehensive programme of proactive engagement with all our stakeholders. And essentially the aim was to win hearts and minds about the benefits of using an adaptive platform approach to advance the evidence base for life after stroke. And the activities included outreach and education, time to build relationships across a wide range of stakeholders, time to build trust in the methods and the team, focused discussion meetings to work through all of the design decisions that are needed to develop a complex protocol. And our aim was to ensure comprehensive clinical input from all relevant disciplines involved in stroke and stroke care and stroke research and stroke research delivery, as well as institutional buy-in from organisations such as NHS England and also the third sector. And you can see the sort of components of our collaborative there on the screen. Essentially, the clinical stakeholders acted as a sounding board for trial development and contributed to the practical plans for implementing platform processes. In particular, they helped us think through these design features that are relevant to platform trials. So thinking about what the platform was going to focus on, the adaptation features, what intervention will come onto the platform, how we're going to evaluate it, and then thinking about processes for how we brought new interventions on and opportunities for standardization. They also helped us think through some of the more traditional things to do with complex intervention trials. So there's a lot of work that goes into complex intervention trial protocols around the intervention and how it can be delivered, whether there's capacity within the NHS to do so and how it's going to be done. So they also helped us think through these things as well. And then another absolutely critical part of our platform collaborative was working with people with lived experience, so both stroke survivors and people who help support them, carers and family and so on. And we recruited to our PPI group in a number of different ways, through adverts and outreach to local stroke community groups and self-help groups. We linked in with public contributors from previous stroke trials from across the collaborative, and we linked in with the research involvement lead at the main charity at the Stroke Association and their network of public contributors. And then we ran our PPI work through both online meetings to take account of people's post-stroke challenges in terms of movement and mobility, and also in-person local group. We had a diverse group of 10 stroke survivors and 2 carers. They included a wide range of stroke impacts, both physical, psychological, communication challenges and fatigue and so on. and we included stroke survivors from different ethnic backgrounds of both men and women. And in terms of what the PPI group helped us do that was specific to the platform protocol rather than just a two-arm trial protocol, are shown here on the screen. So particularly helping us really narrow down the focus of the platform, what interventions should be assessed within the platform, and also what outcomes were important to them. And we did this through PPI meetings that were organised around the key sort of milestones within the Acceleration Award that helped inform the decision making about design features. The PPI group also joined our intervention roundtables, where we did detailed work about different interventions that were candidates for the platform. And the discussions about what makes a difference after stroke really helped us narrow down the focus of the platform to emotional wellbeing interventions. And the PPI activities also highlighted the importance of adapting approaches to be much more inclusive in a population that has diverse and complex needs. And we subsequently developed PPI guidance specific to stroke. So this slide shows the complexity of the collaborative, but you can see on the screen that we had clinical input at an advisory level as platform partners, and also the patient input at the platform partner level, and as part of the team as lay representatives. Clinicians were involved as co-leads of the platform, as intervention leads, and then as deliverers of the intervention. And you can also see we had methodological collaborators across a wide range of disciplines that are needed for these sorts of trials, and Alex will talk through this in a little while. And I just want to say how we arrived at the sort of focus of the platform. So there's a James Lind Alliance priority setting process in this particular area that's come up with the top 10 priorities for stroke, rehabilitation and long-term care. Top 4 are there, next 5 are there. And through the collaboration approach with clinicians, with patients and the public, and together with our review of what were the best candidate outcomes, we ended up focusing on the top priority, which is mental and emotional problems after stroke. So that's where I'm going to end, and I'm going to hand over now to Alex, who's going to talk through how all this was realised in the trial design and the statistical issues it entailed.
Thank you. Thanks, Amanda. Okay, so in order to hone in on some of the design issues and put these into context, we can see depicted here on the slide the patient flow diagram for our adaptive platform trial to test at least 5 non-pharmacological treatments for post-stroke emotional difficulties. So the 5 interventions included a self-directed rehabilitation intervention available to any patient within 6 months of having had their stroke, and then 2 interventions available to patients with symptoms of anxiety or depression, a 4th intervention available to patients with symptoms of anxiety, and then finally a 5th intervention for patients with symptoms of depression. So these interventions were aimed at and targeted to either prevent or to treat emotional problems depending on these patient characteristics. And we included a 6-month usual care control arm, with all interventions being in addition to usual care. So the comparison would be intervention plus usual care compared to usual care alone. And the intention was that patients eligible for the platform as a whole would then be randomised equally between all interventions for which they were eligible for, or to the usual care control arm. And you can see we required a total of 308 participants to be allocated to each intervention arm, and we anticipated that given those different eligibility criteria for the interventions, that would lead to around 740 participants randomised and contributing to the overall control arm. And within that overall control arm, there'd be different subsets of participants that would contribute as the control to each of those separate interventions. And then following randomisation and intervention delivery, patients would be followed up at 6 and 12 months post-randomisation. So this design posed a number of unique statistical challenges. Firstly, by developing an all-inclusive platform, this resulted in a more complex randomisation system and in a partially rather than a fully shared control arm. We needed to consider outcomes that would be relevant for the multiple interventions, and these issues extended to the timing of and the decision criteria for interim analyses. And we considered these issues alongside those common to trials of complex interventions. So I'll share with you now a little bit more detail about each of these, along with how collaboration with Pavel's team helped us to navigate these challenges. So just to illustrate this then, the impact of the intervention-specific eligibility criteria, we've depicted these here alongside the resulting randomisation schedules. So we can see that depending on the patient characteristics of time post-stroke, symptoms of anxiety and depression, patients would flow through to 7 different possible randomisation schedules. And so if we look at this example here, we have a patient within 6 months of their stroke with symptoms of anxiety and symptoms of depression. And this patient would be eligible for all 5 interventions within the platform. And so they would be allocated randomly using equal allocation between control or all 5 interventions. And we estimated that approximately 9% of recruited participants would contribute these sets of characteristics. Similarly, in just one more example, a patient again within 6 months of stroke, but without symptoms of anxiety or depression, would only be eligible here for intervention 1. And so they'd be randomised equally 1-to-1 between intervention 1 or control. And we estimated that a larger proportion of 33 potential participants would contribute these characteristics. Looking now then across all possible randomisation schedules, particularly intervention 1 highlighted here, we can see that, as we heard before, that first intervention is available to participants within 6 months of stroke, and depending on their other characteristics, they could then be allocated to intervention 1 via any one of these 4 randomisation schedules. And similarly, patients could be allocated to the second and the third interventions if they had symptoms of anxiety or depression via any one of these 6 of the total 7 possible randomisation schedules. And so through modelling the process of randomisation to interventions or control, and depending on the interventions open at any time within the platform, we then estimated, alongside also the estimated proportion of people eligible for each arm, the process of randomisation and the distribution, expected distribution of participants that would be randomised to each arm, as well as the proportion of participants allocated to the control arm that would have been eligible and had the opportunity to be randomised to each of those interventions. And this information was really crucial. It informed the degree to which the overall control, the degree to which participants in that control were shared across comparisons for each intervention, and the total anticipated size of the control arm to achieve the 308 controls for each individual intervention. And when working with the Cambridge team, we independently worked through these processes to ensure our estimate of the degree of sharing of the control arm was accurate. It also informed the difference in the likely recruitment rates to each trial arm depicted here. So in the green line, we have the participants randomised to usual care, and below is recruitment to each intervention arm according to up to their target of 308 participants. And we can see that recruitment target in each intervention arm would be reached at a different time, depending on those eligibility rates. And of course, as each arm closes to recruitment or additional arms are added into the platform, that randomisation process changes along with the rate of recruitment to remaining treatment arms. Okay, so moving on to outcomes then. So to reflect the different mechanism of action for different interventions, we decided upon 2 primary outcomes, the emotion and participation subscales on the stroke impact scale at 12 months, and that at final analysis, an intervention would be declared effective if a beneficial effect was observed on either of those primary outcomes. This obviously impacted on our sample size and meant we also needed to account for the correlation, so how closely related those 2 primary outcomes were. And then Pavel's team was able to help work through the impact of this decision on the platform operating characteristics that we'll look at briefly shortly. In terms of interim analysis, we wanted to allow for efficient and early decision-making and platform adaptation. And through our collaborative group, there was a really strong steer towards the inclusion of all promising interventions rather than a pick the winner or a drop the loser type design. They agreed that all interventions should only be dropped, therefore, for futility, but also that because these were complex interventions, that these should be non-binding criteria to allow for flexibility according to other factors such as adherence, safety, and our health economics team also proposed a supportive value of information analysis. Now, we're not working here in the sort of realm of true surrogate outcomes, and so to ensure the timing of interim analysis would not become obsolete, remember we've got a 12-month primary outcome, we selected to use the same 2 primary outcomes but measured at an earlier point in time, and that an intervention would be dropped for futility if it was shown to be futile on both intermediate outcomes. So now we also need to take into account that correlation between that 6-month and the 12-month definitive outcome. And finally, in terms of interim analysis, we also specified that if any interventions were dropped, this would be the opportunity to trigger the potential inclusion of new intervention arms in the platform to replace it. So we were then supported by the Cambridge team, who undertook simulations and analytical derivations to establish how these various design decisions would affect the platform operating characteristics. And they included the power according to different specifications as shown on the screen. So if an intervention was truly efficacious, would we have the power to detect and reach that conclusion? And also the pairwise and family-wise error rate, so controlling our probability of making a false positive claim. And also supporting us in terms of interpreting our interim and final testing boundaries. And we also needed to explore all of this under various different scenarios, imagining that those eligibility proportions that really drove the proportion of sharing of that shared control arm and those correlation estimates between the outcomes and what was the impact of deviations from that. So just very briefly to sort of hone in on one particular aspect of this, we've got some heat maps here that explored the impact of different levels of correlation. So along the x-axis, along the horizontal, we have the correlation between the 6-month intermediate. The x-axis, we've got the correlation between those 2 primary endpoints, and on the y-axis, the correlation between the 6-month intermediate and the 12-month definitive outcome. And the first plot depicts the probability of stopping for futility, and the second, the overall family-wise error rate in the scenario where interventions are truly not effective. So in that case, we want a high probability of stopping for futility, and we want to limit our risk of making a false positive claim. And this really illustrates in the first 2 plots that negligible impact of the correlation between the intermediate and definitive outcomes is shown by that stable colour pattern moving up the y-axis, but as would be expected, we can see an increased chance of stopping for futility represented by deeper shades of blue in the first plot, and also a lower chance of a false positive finding represented by lighter shades in the second plot as the correlation between our primary endpoints increases. And then in the final plot, looking at power, so in this scenario, we're looking at the scenario that an intervention is effective on at least one endpoint. We can see that the colour deepens and the power increases as the correlation increases between that intermediate and prime and definitive outcome, but decreases as the correlation between the 2 primary outcomes increases on the x-axis. But overall, within the realm of plausible correlations, we were satisfied with that we would have appropriate control for these factors. So whilst I've skimmed over much of the statistical detail, hopefully this has provided a bit of flavour of some of the challenges and how we interpreted these through the collaboration. I'll just hand back to Amanda for some final reflections. There you go.
Thanks, Alex. So it was a very quick whiz through. So I think we all acknowledge that platforms are complex to design, and I think complex intervention platforms even more so. So just some of our reflection, that if it's possible, obviously the examples in the pandemic don't fit with this, but for this example, this has taken us a number of years, and to take your time, particularly in a novel area, to educate and upskill the community. There was huge community buy-in for this idea, and that was because we took the time to really carefully explain the ideas. It's important to identify and involve the right people, so get all the right disciplines. This is team science in this collaboration, and to really focus on developing that culture of a strong, collegiate, multidisciplinary, collaborative. And I think that's what we achieved. We had shared aspirations and goals. As with all platforms, try to streamline the platform processes and resources. And I think our sense was, do we need more resources because this is a complex intervention platform rather than a drug platform? And I think some of the resources are different. Sometimes they're greater. So we also had a focus on how we could minimise the resources through remote delivery and decentralised elements, which are a big factor now in trials about efficiency. But also for us, it was really important to have an inclusive platform. So also thinking about the effect of those ways of doing things on inclusivity for the platform. Who does it exclude, particularly with our stroke survivor groups that have different impairments and different challenges? Clearly, an internal pilot was important in this trial to assess some of these things. We haven't had chance to say today how we looked at some of the much more typical statistical issues that are common in complex intervention trials, and I've just listed some of them there on the screen. And I think those issues combined with platform issues, they're a ripe area for methodological research, because sometimes those problems we just couldn't find a solution. It needs some more work to how do we best deal with those. And then I think, maybe this is a reflection in trials in general, really cultivate a sense of resilience. And it's not, in very strong contrast to COVID, it's not a sprint, it is a marathon. It's developing the endurance and so on. And for our first application for this, ultimately, the funder decided not to fund us. It was seen as too ambitious and too complex. So our next steps are to rein it back and to be less costly and start smaller. Frustrating, but we will get there in the end, because the community spirit behind it is overwhelming. And I think this is what really sums it up. Platforms are about collaboration across nations, across teams. It's not about competition. Juliet Bouverie, who's the Chief Executive of the Stroke Association, really summed it up, that this platform trial really would represent a paradigm shift in an area that's really needed in stroke rehabilitation. So I think what you've seen is key to the platform development, was developing this strong collegiate collaboration. And what we would hope is that we would leap forward. It would be this adaptive platform trial really would efficiently provide a robust area and a much needed area for patients, service providers, policymakers and commissioners. So thank you. And most people yesterday were ending with a quote from Doug, so that's mine with our logo. So thank you very much.